Our next panel is on improving health while reducing cost growth. What is possible? I think co-presenting, they're going to go in turn, will be Mark and then Alice, and I don't think they need much of a introduction. In fact, I was trying to identify the one government agency dealing with fiscal or health policy that neither of them had a senior level position, and I couldn't. I thought Treasury at first, but then I realized, Mark, well, you were at Treasury, right? VA, okay. Well, there you go. Good. So we'll start, instead of going through all those agencies, you all know it, and we'll save time by just going straight to Mark, who I mentioned earlier, directs the Healthcare Innovation and Value Initiative in our Engelberg Center. He's going to kick it off, and then Alice will jump in from there. Alice is our Leonard D. Schaefer Chair in Health Policy Studies and directs the Engelberg Center here at Brookings. So with that, I'll turn it over to Mark.
Great. Thank you, Ted, and again, thanks to all of you for being with us today as we're going through a whole set of issues related to healthcare spending growth. As you heard this morning, there's some clear advantages for other public programs, for private expenditures on other services from lowering healthcare spending growth. On the other hand, the main reason that spending has been rising is that there are concerns about the impact of tighter policies related to healthcare on health, and that's something that people clearly value a lot. There is obviously some uncertainty remaining about healthcare spending growth, aside from those predictions that I was able to coax out of our panelists this morning. And moreover, as Bill Gale and others pointed out in the second session, even if the overall spending growth rates do slow more than we've seen in the past, the fiscal pressures facing the federal government and the states are high, and they're going to continue for demographic and other reasons. Given the size of healthcare expenditures, they're bigger than everything else in the federal level except Social Security. It's very hard to see how the spending outlook could be improved without addressing health care. So these are a lot of reasons for trying to effectively and sustainably slow health care cost growth, but there are very different implications from different approaches to getting there, depending on what the composition of the slowdown results from. Higher spending could result from higher prices. Now, Louise and David talked a little bit, or Louise was citing David, talked a little bit about this morning. Charles as well didn't seem to think that this was a major factor, at least at the overall macro level in recent years. Cost growth could be driven by less efficient care, not just prices going up, but the use of medical services and products that become less efficient over time, that have become more widely used despite not doing much for health, and Amitabh talked about some examples of that this morning. What we're looking for is productivity improvement, the reverse of those kinds of steps, getting better outcomes with fewer resources. And there are many examples of this in healthcare, and our paper talks about a number of very productive healthcare organizations, including some large integrated systems, as well as organizations that are focused on treating particular clinical situations well, such as cataracts or colorectal cancer screening or arthritic knees, some primary care practices, some specialty groups that work well with primary care, a number of organizations, especially those caring for low-income patients or integrated with employer programs that deviate from just focusing on traditional health care and start trying to address some of the underlying causes of health problems, even combining traditional medical services with social support or other types of interventions. But these kinds of organizations are the exception in healthcare today. They have not been replicated broadly. There are big variations in costs and in measurable aspects of quality of care in the treatment of many common health problems. In most industries, this variation wouldn't continue. Higher cost and lower quality products and services would be pushed out of the market. But healthcare seems different. Most provider payments are fee-for-service, tied to the volume and intensity of care rather than the impact on patients. So if physicians adopt higher value ways of delivering care, they may get less reimbursement. There's little or no reimbursement in traditional kinds of payment systems for non-traditional approaches to care, like using pharmacists, nurses, or other members of a care team to improve medication use and diet and head off complications for a patient, say, with heart failure. A little reimbursement for wireless monitoring of patients earlier instead of using traditional visits. Similarly, patients typically get paid more, get more reimbursement for the services that they use when they use more services, particularly after they've passed the out-of-pocket limit in their insurance plan, and that's where most healthcare spending occurs. And when people choose health insurance plans, they often get bigger tax subsidies when they choose more expensive, generous plans. In our paper, we review the evidence on a set of feasible policy steps to promote the adoption of the best practices more widely in healthcare, the kinds of features that we do not see widely in the healthcare industry today, to get to a healthcare system that is more consistently high performing. But our intent here, and in much of our work at Brookings, is to push this analysis further. For spending growth in an industry with as rapid technological change and rapid change in knowledge about how to treat patients, as is the case in healthcare, it's not so much about improving care at a point in time as it is about affecting the way that healthcare changes over time, so healthcare innovation. What policies can promote high-value healthcare innovation, not just lead to changes in healthcare based on our notion of the best practices that are possible today? We consider 3 types of innovation to address this. The first is healthcare delivery innovation, better ways of using the medical technologies we have today. This is hard. There are only so many changes that an organization can take on at once. Effective change management is a rare skill. So what policies and other steps can not only encourage healthcare delivery innovation that reduces costs and improves outcomes, but can make that innovation happen faster? Second, we consider biomedical innovation that improves health. This is what most people think of when they think of medical technology. HIV treatments that have transformed that disease from widespread deaths in the early 1990s to a manageable chronic condition. Hepatitis C cures more recently, better cancer treatments, better devices for opening blood vessels or fixing heart valves, as Amitabh mentioned this morning. These technologies tend to increase costs for 2 reasons. First of all, better health is valuable, so these are products and services that are worth paying for, maybe a lot. And think about it, how much would you be willing to pay for a treatment that prevents Alzheimer's disease in a loved one? Second, these technologies reduce some health risks, but may increase exposure downstream to risks to other health risks. So heart disease is replaced by cancer. Cancer may be replaced by degenerative diseases of older ages, including dementia. These factors add to overall healthcare costs. However, if these other risks are far enough out, costs may go down for quite a while. That cancer may only come years later. And then third, we focus on biomedical innovation that reduces costs. So improved medical devices based on feedback with surgeons' experience can lead to safer procedures and fewer complications. Better understanding of how to target drugs or combinations of drugs from diagnostic test innovations. These steps can save money, but may also lead to higher costs if there is increased demand from the lower prices that offsets that per unit savings. All 3 of these types of innovations can increase productivity. They improve health, they can avoid unnecessary costs, meaning a higher performing healthcare system, a more productive healthcare system, but that may or may not translate into lower overall cost or spending growth. And I should add that we also consider another way of potentially reducing healthcare costs while improving health, and it's one that came up this morning. Behavioral changes outside of the healthcare system can reduce health risks and thus would seem to include some opportunities for lowering healthcare costs. Now, the idea of preventing health problems before they happen makes a lot of sense. Reducing health risks means longer and better lives. That's unquestionably good. Most of the influence on health risks actually depends on non-medical factors like choices that people make about smoking and other lifestyle factors, as well as environmental risk factors that are often related to socioeconomic status. But prevention may not lower cost. It's true that these behavioral changes don't come at a price like new breakthrough medical technologies, but they too have downstream consequences for health spending. They mean longer lives with more time to incur other medical costs as a result of more exposures to the risks that were not prevented. Prevention is very valuable, but it may just put off healthcare spending a bit. That does help in the short term. The short term may go on for quite a while, but that doesn't mean necessarily a clear impact on lowering healthcare costs. All that said, one area where it does seem possible to lower costs through preventive steps is in obesity, where this condition has a much bigger impact on the risks of costly chronic diseases like diabetes and arthritis than it has on length of life. To get to a systematic reduction in healthcare costs while improving health, our paper considers three broad types of policies. The first is reforms that affect physicians, hospitals, and other healthcare providers, provider payment reforms. The second are reforms that affect consumers' use of healthcare, including those that affect what consumers pay when they're making choices about their treatments or the physicians or hospitals that provide their care. And we also consider reforms that would impact how consumers choose their health insurance plans. And then the third major category is reforms that could affect individual behavioral choices, which in turn has an impact on those health risks, like smoking and obesity. All of these have in common that they may not only encourage higher value care at a point in time, but may promote changes in healthcare innovation, delivery innovation, biomedical innovation, resulting impacts on health risks that can improve outcomes and lower costs over time. They have the potential to change the structural pattern of spending growth, as well as trends in health risks and health outcomes for Americans over time. So we present some preliminary simulation results illustrating what kinds of impacts these reforms might have and illustrating how they can be implemented together in a way that's more likely to change the whole environment for innovation. And I'm going to talk briefly about the reforms in payments for healthcare providers, then Alice is going to discuss the other types of reforms and the simulations. All of the payment reforms that we reviewed involve moving away from fee-for-service payments that reward providers based on the volume and intensity of services, rather than instead now paying more for quality or how much of a difference the treatments make for a patient, or payment systems that are not tied to the actual intensity of services. Now, the one that comes to mind as a clearest example of this is capitation. This is in which a set of providers assume a full financial risk. They combine insurance with healthcare delivery in this payment system with reimbursement fixed. Any steps that providers can take anywhere in their delivery system to reduce costs translates into net revenues. This does encourage lower costs, and there are examples of integrated systems like Kaiser and Geisinger that use this capitated approach to deliver more efficient care. However, most healthcare providers today are too small and fragmented. They don't have the information technology and coordination systems that might be needed to manage overall health and financial risks. Many provider organizations that tried to do so in the 1990s failed, and as we heard earlier today, that period of slower growth was followed by an acceleration. An alternative is taking steps in this direction, creating a pathway towards more person-based payments. Accountable care organizations illustrate this. Instead of full capitation, this is essentially setting up a second track of payment. It's not replacing fee-for-service, but it's alongside it with the possibility of shifting from the fee-for-service track to the patient-level payment track over time. An example of this is the Medicare Shared Savings Program, and some of its early results show that some, but not all, the participating organizations are lowering their spending trend. Private plans have gone even further in this regard, such as the Alternative Quality Contract implemented by Blue Cross of Massachusetts. This is not a full risk or fully capitated program, but it's moved well beyond shared savings to promote innovation over time through improving delivery, improving data systems, improving the infrastructure for coordinating care and healthcare delivery. Increasing experience over time with these systems has also led to opportunities to go further, to move towards more of a capitated payment system and more of a focus on redesigning care. Some of the early results suggest that lower spending levels and growth in spending has extended over the first few years. Another potentially reinforcing alternative in provider payment is bundle payments. These are overall fixed payments, not for everything, but for a set of services, a case-level payment rather than a payment at the person level. This has been used most commonly and successfully for discrete procedures like bypass operations or hip replacements or colorectal cancer screening, and a number of providers are using it for some of their non-capitated practices. It's kind of an intermediate step to get towards more capitated payments. Medical homes that shift at least part of fee-for-service payments for primary care physicians to case-based payments are another example of this. So these programs are expanding. They are showing some preliminary but promising results. And as you heard reflected this morning, there's some reasons for optimism that these reforms can make a difference, at least in improving the care that we're getting and avoiding some waste, even if it's not yet clear that these steps do enough to promote cost-saving innovation while continuing to encourage valuable, if costly, biomedical innovation. Now, David's going to, I think, have some more to say about this topic in just a few minutes, but I did want to highlight some steps that would help. One is better and more consistent measurement of quality and cost, not just to tie to these payment reforms more confidently, but to give consumers more confidence about these alternatives to simply paying more for services, and to enable more effective consumer choice. Also, these steps can help us design policies and regulatory enforcement mechanisms to make sure that any new steps in care reform, consolidation, other steps like that really are improving care and not just contributing to higher prices. Finally, better support for providers to enable them to take steps to improve care. For example, many providers don't have the data systems in place or the ability to identify where the biggest gaps in quality and cost savings are in the short term as well as in the longer term. And as I mentioned before, I think our findings are that it's best when these kinds of reforms aren't used alone, and Alice is going to talk about some complementary reforms that can help engage consumers. Thank you all very much.
Thank you, Mark. Mark has talked mostly, although he was all over the map, about Mark has talked mostly about payment reform and its potential. And if you listen to the debate on how to control healthcare costs, I think you hear several themes, but two of them are payment reform and competition. We don't think these are alternatives. We think they are necessary to use together. But if you listen to some extreme free marketers, they will say, just treat healthcare like any other product. We believe in competition and consumer choice, and what's so different about healthcare? Well, as everybody in this room knows, healthcare is really different. It's not like cars and refrigerators. In the first place, as somebody noted this morning, the consumer has to rely on the expertise of the medical profession. There's asymmetric information, as the economists say. There is mostly third-party payment, and it's increasing, as Louise and others showed this morning. The out-of-pocket costs are diminishing to the vanishing point. And spending is very concentrated in large, expensive episodes. So you can't treat healthcare like any other product, but there is a role for competition and consumer choice. And we focused on three types of potential reforms that illustrate the potential for introducing more competition and more informed consumer choice. One is high deductible plans, usually combined with health savings accounts. One is value-based insurance designs, which we think has actually probably more potential. And then competition among health plans on exchanges, which we're dealing with in a big way. High deductible plans, as you know, make the consumer responsible for low dollar or routine expenses, office visits, tests, often drugs. But what is routine for a high income person may not be so routine if you don't have much income. Many studies confirm that consumers spend less when they're spending their own money, which is not surprising. And most of the effect of this kind of high deductible plan is on drug purchases. On the other hand, there's also the worrisome evidence that consumers defer high value spending, vaccines, cancer screening, effective drugs, and some evidence that they use the ER more if they are skimping on the preventive expenditures. So while there's some role for this, we don't think it has a great one. High-value insurance designs are sort of interesting and promising. Here the concept is that the co-pays that the consumer pays are lower for high-value drugs and treatments determined by research. And so you have the potential to improve health and to save money at the same time. And there are a few examples that are really quite spectacular. Pitney Bowes and their company plan reduced copays for long-acting asthma drugs and got a 22% reduction in ER use by asthma patients and a 62% reduction in avoidable hospitalization. That's a small population, but it's pretty spectacular illustration of the point that this kind of design can make a difference. Then we turn to competition among plans on exchanges. Now, that concept is very appealing, and it's appealed to the Massachusetts and national designers of health plans. The concept is that plans compete on regulated exchanges. One may have to subsidize consumers to make them affordable, make the plans affordable, as in the ACA. You need transparency on the premiums, and ultimately, one hopes much better information on the outcomes, on what actually happens to patients in those plans. The hope is that consumers choose the best plans for them, and the insurers respond by offering plans that improve outcomes and restrain costs. Part D of Medicare is a good example of this basic approach, although it's limited to prescription drugs. Part D, as you remember, was dogged by anticipation of very high costs and the doubts that older people could make the choices that they needed to make, but it has proved quite effective. The costs were much less than anticipated, and it turns out that most of us old folks, with a little help, can actually make choices among drug plans. The ACA, of course, embodies the principle of competition on a transparent exchange, but it's really too soon to say anything definitive about the ACA, although there is some suggestive evidence that the competition has lowered premiums in some places where they were extremely high. Premium support reform for Medicare is another example of this approach. I think quite a promising one, despite its misuse by my good friend Paul Ryan. But I won't go into that because we haven't actually tried it and we don't have any estimates of what might happen. One can, I think, imagine a future for the U.S. healthcare system which involved major shifts away from the fee-for-service system toward capitation and bundled payments with competition among the plans and user-friendly information. When one can imagine going that way. We also looked at new emphasis on prevention and wellness, and Mark has talked a little bit about that. It isn't just diet and exercise, it is redesigning communities. It's a little hard to get much exercise if you get shot when you walk out the door, and it's hard to have a good diet if you don't have fresh food available in your neighborhood. But as Mark has pointed out, the prevention of disease has very positive effects on the individuals that live longer and healthier lives, but it doesn't necessarily lead to reducing total spending over time. The two specific proposals that we did look at had to do with smoking and obesity. Smoking definitely leads to longer life, but lower expenditures if you're a non-smoker. But those seem to more or less cancel out. Obesity is promising because obese people actually don't have shorter lives, or not much. They do have higher health expenditures, and that suggests we might have the possibility of a twofer here. And finally, let me show you some preliminary simulations that we did. This was a very rough stab at answering the question, how much difference would it make to healthcare spending if specified scenarios of successful reform unfolded? 4 of our scenarios involve different assumptions about the impact of biomedical innovation on longevity. 3 involve successful efforts to improve the efficiency of healthcare. And 3 involve success in changing behavior on smoking and, changing behavior. And so let me talk you through the slightly confusing slide. We used the USC's Schaefer Center's Future of the Elderly model, and we were working from the CBO baseline and Louise's up and down scenarios. And we ran these out to 2020, 2030, and 2040. If you think that the moral of this chart, I think, is if you think that sustainable growth in healthcare spending is equal to GDP growth, then we really have a lot of work to do to get there. Medicare spending would have to be 18% lower by 2040 than the baseline. Now, if you look at the second set of the little low ones there, that's what we found out about some specific innovations. And basically, medical innovation works in the wrong direction, even if you constrain it to innovations that have a fairly reasonable payoff in terms of the cost of the life expectancy increase. In the case of delivery system reforms, we didn't attempt to simulate specific payment reforms. We just essentially said, what would happen if you had a whole package of payment reforms, bundled payments, ACOs, whatever, that succeeded in reducing spending per year by specific amounts. And what you can see is you have to reduce by somewhere between 1% and 1.5% per year to get down to the spending only increasing as fast as GDP. That's a lot. And finally, our fairly aggressive reforms in obesity and smoking, using this model, we're assuming that people coming into the model at age 51 were 20% less obese than they are now. That's pretty successful. Neither that nor the 7% reduction in smoking gave us anything measurable in the time frame that we were looking at. So our final bottom line is upward pressure on healthcare spending is likely to come from medical innovations combined with the demographics that are already built into the baseline. This spending may well be worth it, but don't count on it to reduce cost. You have to make major efforts on efficiency of care to get to where we want to go, and successful efforts to facilitate healthy choices and create healthier communities would create a much improved quality of life. We should do them. We should do them for their own sake, but not because they're likely to slow the growth of healthcare spending. Thank you.
Okay, I think first up for discussant, we have Joe Antos. Where is Joe? There he is. Joe is the Wilson H. Taylor Scholar in Healthcare and Retirement Policy at the American Enterprise Institute. He, too, has a long and illustrious bio, which you all should have. Among the senior positions he's held at HHS, OMB, and CEA, and he was health advisor to CBO. So I'll hand it over to Joe.
Huh. Maybe I will. Exactly. Okay. Okay. Well, thank you. The paper is well worth reading. It's very informative. It addresses a lot of the things that we talk about in Washington all the time about structural changes that could potentially put a dent in the growth of healthcare spending. One of the things I like about it, actually, is the title, because it says improving health while reducing cost growth. It's improving health. Oddly, that is the outcome we want. It's not improving the health system. We don't care about that, do we? Really? If we could improve health, we really wouldn't care much about how we did it. So, unfortunately, a lot of Washington conversations start with how do we fix the health system, and they end with how do we fix the health system. And, of course, the conclusion is pretty bleak, as, in my opinion, Alice and Mark laid out. Nonetheless, I think that's the right orientation. I don't think this paper, I don't think any other paper that I've ever seen really makes that leap, tells you exactly how you do it, but at least we have to know what we're aiming for in order to get the policies aimed in what we hope are the right directions. I want to congratulate also the authors of the paper, and of course I include Alice and Mark, but especially the hardworking staff who we know really did a good bit of the work. It's a very informative paper. The references are terrific, very fact-filled. Let me just say a few words, a few reactions to the things that people have said here. First of all, on the question of is the war against health spending growth over? Well, I was relieved to see that it didn't seem to be over as far as the first few panels are concerned, but I have a feeling that my fellow discussant might be declaring victory soon, so I thought I'd address that a little bit. As they pointed out in the first panel, we've seen cost rates. I should say spending rates. If I ever say cost, just edit that out and think of it as spending, because the connection between spending and healthcare and cost is a very difficult one to fully establish. But spending rates, we've seen them slow in the past. We've seen them bounce back up. I think what's unusual about the current period, there are several things that are quite unusual about the current period. Certainly the fact that 2002, at least according to the National Health Expenditures, was the peak of health spending and spending growth rates, year-over-year growth rates. And we've seen growth rates come down since then or stay stable at a relatively low rate compared to history. I think that's pretty unusual. We had a very sharp, it was brief, but a very sharp recession. It was an exceptional economic period, and the recovery has been really quite slow. I think that's highly unusual. And then we have the Affordable Care Act, which was enacted well after all of these things occurred. And it is really unusual for people outside of this room to claim that the Affordable Care Act is the source of all of these perhaps wonderful things. It's not clear that they're wonderful, but we can observe certain things. I think the real danger here is extrapolating from the recent past that we don't understand at all well. It is different from, I think, the past experience, but we don't understand it at all well, and assume that it's going to go forward in some manner, such as we've seen in the last few years, that the growth rate isn't going to suddenly accelerate. I think that's very risky for lots of reasons. But the most important reason is that if we really have had some sort of structural changes, maybe caused by employers responding to healthcare costs, I think that may be part of what's driven a lot of what's gone on here. If we've had structural changes, remember the structural changes can be reversed. You can have structural changes that come from policy. They can be reversed. You can have structural changes that don't come from policy, but come from the private sector responding to conditions that they face. Those can be reversed as well, as we saw in the 90s and we're liable to see again. So I think that's a real issue. Let me say a few things about, and then one last point, which is that even if the rate of growth has slowed down significantly and it's permanent, if that's true, that's certainly no reason not to work on improving efficiency and effectiveness of healthcare, because there's still waste in the system. We already know that. So if you can remove some of that waste, that means that we can improve people's standard of living in other ways. Now, ideally, we would let people keep their money. We wouldn't just tax it away from them and decide that they need something else without giving them a voice in the matter. But in any event, I think that is an issue. A few points about the structural changes that Alice and Mark wrote about. One of the things that they didn't really address is the dominance of the Medicare program in setting the atmosphere for health plans and health providers and beneficiaries as well, citizens as well, consumers. The Medicare program is not only the largest single payer in the system, but it's also the most important regulatory body, and its rules move out to the rest of the system in ways that aren't always that predictable. So there's a kind of a spillover that's a negative spillover from the Medicare program. Its inefficiencies, its mistakes are transmitted throughout the healthcare system, and one can only go so far outside of the Medicare system to deal with that. And so any changes that are meant to improve the efficiency of an individual health system, Geisinger's attempt to make that next push forward, or for that matter, the little health plan or the individual physician's office that we don't talk about that much. They are limited by the rules that they live within. The coding systems and all the other things that go on with Medicare, they're not going to invent new coding systems. They're going to continue with the way Medicare does it because it doesn't make sense to do it another way, but that inevitably changes the way you think about how you deliver healthcare and what healthcare actually means. Another point that I wanted to make is, if it's a good deal, should you automatically buy it? I think this is something that you'll see in the paper that I reacted to. The idea that you could do a cost-benefit analysis and say, well, the benefits are much greater than the cost, and then what? Well, if somebody else is paying for it, then absolutely, I want you to cover it. But if I'm paying for it, I might have a different opinion. And even if somebody's giving me a subsidy, but they're giving it to me in a way where I understand that it is my money and that I get to make choices about it, I'm liable to have a different decision. And so this whole idea that comparative effectiveness research is going to somehow give us a breakthrough here on what we should cover, I mean, it's interesting. It'll generate information. Some of it will be correct. Some of it we will discover later on wasn't quite right. But I don't think that it's going to really solve in one fell swoop the policy problem that a lot of people who pushed for that legislation thought they were going to solve, which was the cost problem. The cost problem ultimately depends on people's valuations, and if you push it up to a higher level, say the Medicare program, then you have the problem that since the information changes all the time and people's judgments about things change all the time, that you're going to have to do something like what Mark did when he was administrator of CMS, which was coverage with evidence development, except you need continuous evidence development and continuous judgment about what to cover. That doesn't just apply to Medicare, that applies, of course, to all health plans. But it's a major challenge, and it really raises the question about whether we will really be able to solve that medical technology problem. It's constantly moving around, but our understanding of how it works is constantly moving as well. And so I don't think we will see hard and fast decisions ever in this space. Thank you.
Okay, next up is David Cutler. Like Mark, Alice, and Joe, David has not held a senior position at the VA, but he has served on the CEA. We got to address this, I think. Served on the CEA and NEC. He also has lots of affiliations, including research associate at MBR and member of the Institute of Medicine, and he's the Otto Eckstein Professor of Applied Economics at Harvard. So welcome, David.
Thank you for inviting me here. I feel a little bit like the organizer of garden parties invited to the skunk convention. So I will try and give you a sort of slightly different view about what's possible. Let me start off sort of, the whole day has kind of been based on what I call what I'm calling the trend and wiggle model. So this is a very sophisticated economic model of medical spending where there's some trend, like, that healthcare spending will increase because of technological change by something on the order of GDP plus 1% or so. And then there's some wiggle, which is everything else. And sometimes the wiggle is a little bit higher, and sometimes the wiggle is a little bit lower, but basically you're sort of going to be on that long run trend, except for those periods of time where something unusual is happening in the healthcare system. And I confess that actually I've probably written more papers on the trend and wiggle model than anyone in this room, with the exception of potentially Mark and maybe one or two others. And so after thinking about this and sort of viewing this for some time, what I want to conclude is that I think that that's actually the wrong model. And I'm ashamed that Mark wrote so many papers about this kind of model. So why has the model gone wrong? Well, there are a few things about it. One is that I think the focus on technology was sort of right in a period of time, but it's actually wrong now for a few reasons. One is that when technology really costs more, it's when there's sort of no way to treat someone. So if you can't treat someone, think about Alzheimer's disease, and then you develop a way to treat them, then you're sort of adding that into the armamentarium of what you can do, and that winds up being very expensive. That's actually an increasingly small share of diseases because we've sort of developed so many things. What happens now both is that technologies are replacing other technologies, so think about minimally invasive surgery relative to open surgery, or else what we're discovering in a form of sort of reverse technological change is that many of the technologies that we thought were valuable are actually somewhat harmful or not very good at all. And Amitabh Chandra raised this point this morning, and you can think about it, for example, stent insertion, which the COURAGE trial showed we were doing way too much, and as a result has come down a lot, to things like cesarean sections, which have come down in a number of cases, as well as a variety of other different kinds of technological changes in medicine that were once thought to be quite beneficial. So the net effect, I think, is probably actually smaller than at least it used to be, and certainly than we're still giving it credit for. Further, as Amitabh said in his comments this morning, and as Louise pointed out quite nicely in her paper as well, income is not a determining factor for the bulk of people with insurance the way that it was. If income matters, it's going to be much more subtle than just people are richer and so they decide they want to spend more. There may be some of that coming through the public sector, and there may be some of that for people whose insurance is not particularly generous, but that's a relatively small share of the population, again, as Louise was showing us this morning. So instead, I want to think about a different model, and here's how I'm increasingly thinking about the healthcare sector. And that is, there's a sort of supply side which determines how much it costs to treat a particular condition. Okay, and here I mean a condition here that is treat someone with a particular disease, so an episode of care. I don't actually mean doing a surgery or having them stay in the hospital for a day, because of the substitution across treatment technologies is actually extremely important here. So there's a supply side, the efficiency of which determines how much it costs to treat a particular condition. And then there are various demand and other side constraints in terms of what it is that people actually receive. That is, do they want to undergo the procedure given their cost sharing? Is the system set up so that they're allowed to do it, or is there constraints on doing it, something like that? It looks fairly standard, but actually once you start to think about it this way, a few things come out which I think we probably don't pay enough attention to. And the first one has to do with the supply side, the efficiency with which medical care is delivered. So if you look not at the sort of level of any particular treatment, like say opening someone up to do something to them, but if you look at sort of broader measures of system efficiency, the thing that is inescapable is that we're wasting an enormous amount of resources. So these are either resources on procedures which are of no value whatsoever, or procedures for which there are other cheaper technologies which are just as valuable, or diseases that we're not preventing in the way that Alice and Mark were talking about them, that if we prevented them, we could save a lot of money. That's not true about all kinds of prevention, but it's true about a lot. Or prices that are too high because we're doing things at the wrong providers, so we're paying 3 times more for the same thing than we need to because we're doing it at very expensive places. Or because of administrative costs involved in the billing and operations management, which is about 10 to 15% of medical care is probably wasted that way. Fraud and abuse in some areas of the country. If you put those all together, there's a range of estimates about what is the inefficiency associated with medical care, but on the low end, it's probably about a quarter, and on the high end, it's probably about a half or so. So you sort of start off there and you say, okay, so there's that efficiency. Does the system actually know how to get rid of it? And the answer is yes, it's actually not that difficult to get rid of it. This is the transition that happened in essentially all of American industry. You think about processes of care, so that's sort of the benchmark here, where the process of care is the treatment of a patient with a particular condition or set of conditions. There are a variety of different things about the design of the operating system that the sort of writ large operating system that feed into those processes of care. And what a good system does is it always looks at the outcomes of those processes of care and says, well, how do I do those and get better? So you do performance measurement. That's a key in every high-functioning business. That then feeds back into some kind of executive leadership that then influences the mechanisms that in turn affect the processes of care. And actually, not only that, you then set a strategy which is going to affect how you organize the institution, which in turn is going to affect the processes of care, and you get a performance loop. And so if you sort of look more generally, there's a kind of high performance loop. And these are the kinds of things that people think about as sort of the one-time savings from running the operation more efficiently and so on. We have, again, including myself, made a big distinction between one-time savings and reductions in the growth of spending. I think that distinction is now an entire mistake to make, because it turns out the exact same things that are associated with performance improvement at a point in time are associated with performance improvements over time. One way to say it is in healthcare, it's when you see the processes of care, you observe where the anomalies are, and those anomalies lead you to think about how to do adjustment, both in terms of analysis and redesigning systems, as well as adjusting the care processes themselves. Indeed, this sort of learning loop is exactly what goes on in most big firms. That's why in manufacturing, the price of most services, the productivity of most goods production goes up year over year. It's not that there's some inherent technological change, it's that they're always learning. They're both striving to be the best in terms of the performance loop, and they're striving to always learn what's better in terms of the learning loop here. So this is actually something that any good firm can do, and it's not immune to healthcare. This process would apply throughout healthcare production, whether you think of production as the mass production of routine treatments. Very standard cases, you see any number of people with a similar stage of cancer, similar stage of chest pain, or so on. Not that they will all follow exactly the same path, but you can lay out the path that people will follow, and then you can adjust them as you're going on, to the situations where it's really customized production of treatment of the uniquely ill. So people who are seriously and persistently mentally ill, they're all one-off, they're all different, but the process that you use to deal with people can be relatively similar to the management of administrative and payment kinds of systems. All of these things are amenable to changes in production, and thus we can save a lot of money. My conjecture is that when we do have a more efficient medical care system, we will see reductions in the relative prices of healthcare. So if you look over time, goods-producing industries have had very low price increases, and service industries like medical care and education have had very high price increases. But there's nothing inherently about that. As I know from working in education, it's an inherently inefficient production process for which one could do a lot better, and the same is true looking throughout the healthcare system. So we would have very big, so if you address the supply side issue, we would have enormous reductions in the cost of treating people. Then the question is, how would that factor into the demand for care? That is, would we wind up doing it on a lot more people and spend our money that way, which wouldn't be bad, but would not save us much in money? Or would we realize the savings and reduce prices as lower spending? That is, would we do the equivalent of put a flat screen TV in every room in our house, which now that they're cheaper, we can afford to do. So we don't save that much money, but we get much more and better TV viewing. Or would we just decide that we want to spend less? My impression is that there's actually not an enormous elasticity of where we would treat more people. Again, in part because a lot of the things that people get, we're already diagnosing and treating a lot of people. So there just isn't that much of a woodwork effect. Although there are exceptions, certainly particularly diseases associated with chronic decline among the elderly, such as Alzheimer's or mild dementia. But keep in mind here that it's actually not age that matters for spending. Getting older does not really affect your spending. It's getting sick that affects your spending. And as people get older and healthier, they're actually not going to spend as much as if they were older and getting sicker. So if I were going to say, what are the two things that have not been talked about today that we really ought to talk about in terms of thinking about health spending growth? Here's my nomination for the two of them. I don't want to dismiss the things here, but I think there are two things that we really don't talk about. Number one is, in terms of the efficiency of the healthcare system, the biggest missing ingredient to me, once you address the sort of payment incentives and so on, which we're on the way to doing, the single biggest issue to me is the managerial capacity of healthcare, which is extremely poor by standards of most of American business. There are surveys that are done on how well managers and firms are managed in different industries. Manufacturing in the U.S. is extremely highly managed. 5 here is the best you can get. 1 is the worst. Healthcare is much less well managed, both in terms of the mean, that is the mean management score in hospitals is much lower than in manufacturing. And you see scores in hospitals that you just don't see anywhere else. That is, there's a degree of poor performance that you just don't see. What is that poor performance? These tend to do with things like, do you set realistic but stretched targets? Are you collecting the information that you need to know if you're meeting those targets? What's the feedback like? Are people who do well rewarded? Are people who do poorly either let go or help to get better? That is sort of basic processes of how do you run something well. And probably, I think at this moment, once we've changed the payments as we're doing both in the public and private sectors, the single biggest obstacle towards achieving the efficiency gains is actually the efficiency with which institutions are managed and not necessarily the incentives that they're operating under. So that's the first thing. The second thing that we don't talk that much about, but which I think is critically important here, is where are people getting sick and how long a time period are people getting sick? And what really matters here is, are you in a situation like death from cancer, which is relatively rapid in the final stages, and you spend a lot, but there's sort of a fixed amount of time. And so once you're treating people, you're not going to get that much more expensive. That's why cancer cost increases are slowing down. Or are you in a situations like Alzheimer's disease, where there's a very long period of time over which you can do a lot, or we suspect there will be a lot you can do that will be very expensive. Actually, what we know about that so far is that over the past couple of decades, even as people are living longer, they're living healthier. That is, disease and disability are being delayed until the period just at the end of life. Virtually everyone who dies in the U.S. is disabled for some reasonable amount of time before they die. Farther away from that, the rate of disability is actually falling. So on both of these accounts, I want to be optimistic. That is, we are have the principle to, we now have the policies in place that would allow efficiency gains to be manifest, and we can change the managerial capacity of healthcare, and that our demand for care is at least shifting in a dimension that's not always associated with greater spending, but really compressing it into a period of time. So thank you. I will stop here.
So thank you, everybody. Thanks for the presentations. I'm interested in getting some crosstalk on the panel, and I might even be calling some people on the crowd. I wanted to start with David. I think, did I get it right? Did you say you feel like a gardener at a skunk party? Was that the phrase?
It was a lawn party organizer.
Oh, I see.
At the skunk party.
Okay, I got it. So I was going to ask, first starting with Mark and Alice, and maybe our original panelist, maybe Louise, to start from the beginning also. In my analogy, are you the gardener or are you the skunk? Meaning, what do you think of David's argument? He I think, had more of a more optimistic view. And Mark, what was the phrase, a trend and wiggle? I've never heard of the trend and wiggle model, but as the key trend and wiggler on the stage, do you want to come to the defense, or have you abandoned that model with the big red X?
I don't know if I've ever been called a trend and wiggler before, but if David
I wanted you to demonstrate it for
perhaps,
everybody.
That'll be later if we run out of questions. But I think David and I have done a lot of work together in the past on what we're getting for what we're spending, and David's written a book about Your Money or Your Life, which had a main point about how we've been doing on average in healthcare spending over time. So unquestionably, spending has been going up. Along with that, though, there have been improvements in outcomes for most of the common conditions that lead to serious health risks and premature deaths. Not all of them. David highlighted Alzheimer's. I'd expand that to degenerative diseases of aging and many types of cancers as well, where we've made some progress but still have a long way to go. And I think the upshot of all that work is not don't worry, be happy, because we're spending more but getting more for it, but rather we have been getting a lot of returns on average for healthcare spending. At the same time, there are a lot of inefficiencies in the system. And I think if I was going to paraphrase David's findings, it would be that, look, we now have some opportunities and some growing evidence that we can get those persistent, large inefficiencies out of the healthcare system, so we can go to our lawn party, kick out the skunks, have our cake and eat it too, with better health and a much more sustainable outlook for healthcare spending. I think the challenge is that while it's certainly a hope, we're not there yet. The kinds of improvements in efficiency that David is describing that are common in other industries are not yet common in the healthcare industry. Those kinds of variations in care persist. There's another round of stories fairly regularly about, lately it's been post-acute care spending or use of certain services by physicians in Medicare, but we're certainly not done yet. And I think that encourages, or I think we might agree, is that the kinds of policy steps that we outlined have the potential and may be doing some good already, but if anything, I think we need to redouble our efforts to be more confident about the impact on spending. Sorry, just one more point too, is that as we try to emphasize in the paper, is that it's not just about being more efficient in treating and using treatments we have now, but I do think there is a good bit more biomedical innovation coming, and like just Alzheimer's disease is sort of like saying just the Pacific Ocean in terms of things that people worry about and that really impact their quality of life. And I do think we have some cost increases ahead as a result of further biomedical progress, and that's not necessarily bad news.
So Alice, let me just one quick setup on this. I feel like I've been kind of whiplashed between optimism and pessimism throughout the day. I know you well enough to know you tend to be an optimist.
Not about everything.
Not about everything. Joe mentioned one of the key words he liked in your title. One of the key words I thought about your title is the title was what is possible, not what is likely or what we're going to see. So I'd like to kind of, in the context of what David talked about where you think we are, what explains the recent trends, if you take the mix of what you and Mark had considered and you add the caveat, condition it on being likely, given the current context of health policy, should I be optimistic or pessimistic moving forward?
I don't know. But that's exactly what I wanted to come back to David on. Efficiency is a wonderful thing, and if you're CEO of a manufacturing company and your shareholders and even your employees, no, not all of them, will be pretty enthusiastic about efficiency reforms, and they don't have much choice because they're in a very competitive environment anyway. And so we increase productivity greatly in manufacturing industries. But I'm much more skeptical. Who is it who is going to say, we have to do this? We don't have a CEO of healthcare. We aren't likely to have one. And the cultural and political resistances to a lot of the things that are implied in your nice circles and efficiency diagrams, they're just enormous obstacles. I think that the atmosphere is changing a little bit, that people do realize, both in the healthcare industry and maybe in the political system, that there's a lot of waste and we have to get rid of it. But one person's waste is another person's income. And the political clout of the providers and the pharmaceutical companies and everybody who stands to lose here if you get more efficient is enormous. And we know by the experience of the last several years that even Dumbo things like competitive bidding for wheelchairs are who's against that? Well, the manufacturers of wheelchairs. They're pretty powerful. So it isn't a slam dunk.
I'm going to turn to David to respond also. The other thing, the question, I guess, along the same lines, I think the story you're telling is the story of things are getting better. There's all these efficiencies that we've all identified in that now we're doing better. I guess my question is, what's changed? Like, why didn't it happen 5 years ago? You kind of made this comparison to other products. That those other products didn't have an abrupt change. So I'd love for you to respond to what was said and also give me a sense of what you think the key driver of what the change is as you've described it.
So it came up, part of this came up a little bit this morning with the discussion of states and localities and employers. I've been doing a modest amount of work with the state of Massachusetts. We passed legislation a couple of years ago to try to reduce medical spending in the Commonwealth. So Massachusetts officially has a target for the growth of medical spending, which is that it shouldn't exceed the growth of the long-run average growth of the economy, which is 3.6%. So that's number one, and everyone's afraid the governor will get mad at them. Number two is they're deathly afraid of what Washington will do to them, both through Medicare and Medicaid. We also get a lot of NIH money, so they're quite afraid of that. Number three, we have employers that are moving into higher deductible policies or selectively tiered or limited higher deductible policies. Number four, we have Medicaid payments that are still going down. So the net effect is that if we want to keep coverage gains, we have to save money, and everyone knows that. So what happens is, and it comes directly to Alice's point, what happens is not at the state level, but within the institutions think about what they need to do. And they say, look, our revenues are not going to increase any more rapidly than 3%, 2%, whatever it is. If we want to have any money for any other things, we'd better figure out how to get more efficient. Once it's a conversation within the institution, it becomes a very different conversation, because now you can have the 17 oncologists sit down together and say, who's ordering 3 times more MRI scans than the others, and why don't we eliminate those? Why don't we just sit down and talk about it and eliminate those? And that's actually the consistent story that you get, which is that when you impose something on the physician community, as you said, no matter what the community is, they always rebel. When you go to them and you say, look, here's an opportunity where together we can do better, and by the way, the financing works out, and we're going to guarantee that we're not going to cut the drugs that you think are life-saving to these patients, but we're really going to go through just the things we do that turn out to be bad, both too much and too little. The too little often has more spending down the road. The too much has an immediate too much spending. They actually find a way to do it, and sort of story after story shows you can cut spending by 5%, 10%, 50% in a disease category, in every single one of them. I've yet to see any example where anyone looked at any disease category and concluded they couldn't save money, significant amounts of money. So that's where the hard work comes. When you observe them now, they're sort of struggling through it, and you look, I don't teach at the business school, but you look and you say, gee, if they just had a little bit of business school education here, like they would have recognized that this was going to be a problem and they would have sort of known to work through it. And that's really sort of the missing ingredient, is their ability to run these. What makes me hopeful is they can figure it out. What makes me scared is they don't actually know how to do it, and so they're sort of flying blind, and when you're flying blind, you do tend to crash the airplane on occasion.
I want to take turn it over to you, so if there's questions from the crowd right there in the middle table. Can you wait for do we have microphones? Oh, you have microphones there. No, you don't have to wait. There you go.
Hi, Mike Miller from the NGA. I had a quick question for Mark and Allison about the models you guys have in this figure. This is just Medicare, right?
That's
Savings,
right.
because I've been doing a bunch of work around smoking cessation, and there seems to be a lot of good evidence that reducing smoking rates can save a lot of money for state Medicaid programs or private employers. The Medicaid conundrum is that the people live longer, so they're on Medicaid for longer, and that the excess spending comes in the tail. Is that roughly accurate?
I think that's about right. And with smoking, you can actually reduce some upfront risks and some risks down the road as well, leading to a longer life. And that may be a challenge for Medicare spending down the road, but it's absolutely worth doing. And in some of the simulations that we did, we found, and you saw that, I mean, they're pretty small effects compared to some of the other things that we looked at on spending, but did lead to some savings even out 10, 20 years before those longer term impacts kicked in.
Louise, I was going to, yeah, go ahead.
I want to ask a follow-up on that and another question as well, which is on, could the smoking stuff, so you just presented sort of the present value, could we possibly be right now in a place where we're saving money? Could that contribute to the sort of decline in Medicare? Have you looked at?
Yeah, are we out of equilibrium in terms of people having reduced health risk now and not getting
For
them
later.
Yeah.
What's going on? And the other question I had, and David, you've done work on this too. So this idea that you can save a lot of money if people just take their drugs. Do we think that Medicare Part D might also be responsible for the decline in Medicare spending now, that we're sort of got efficiencies from that? And do you have any idea if that's big enough to matter?
Can you repeat the question?
Oh, sorry.
She didn't speak into the...
The answers can which one are you going to answer? Go
Let me
ahead.
take Louise's.
There's two questions. One is as Mark and Alice talked about, the decline in smoking in the long run could have an increase in cost, but in the short run it could decrease costs. So maybe that's contributing to the slowdown now. And the second one, what was the second one?
Part D.
Part D. Is Part D contributing to the decrease? Go.
So there have been a number of studies, as you know, on the impact of pharmaceutical cost sharing, both on pharmaceutical use, which is pretty common. You reduce copays by $5 or $10, and you get 5 or 10% more people to take their meds, and on use of other services. The use of other services, the literature is not totally clear. So you've got some studies that say there's no impact and it's sort of complementary because you have to go to the doctor to get your prescription. And there are other studies that say there's an offset, which is that that you can actually reduce, say, hospitalization spending. But to come to your broader point, the sort of Bunton-Levine CBO paper on Medicare basically found it was sort of all this unexplained part of what we thought. And part of it may be that the need for care is lower, and part of it also is probably that the decisions that the providers are making about which care to give people in different kinds of settings is actually changing as well. And we see a lot of that with these things. So
Less hospitalization, for example.
much less
yeah.
hospitalization, much less, basically take every drug that was supposed to be a top seller in the past 8 years and it's underperformed. Mm-hmm. It's the only industry that I've seen that has a worse forecasting record than economics. It's people who forecast pharmaceutical sales. There's no one else who's worse. And so everything is sort of coming in relatively low.
But couldn't that be an offset from, so the private sector has a lot of income pressures, doctors change their practice styles in response to pressures that are sort of related to the recession, that feeds out into Medicare, and then those pressures relieve, and then all of a sudden we're going to see, the prescription drug demand, just jump up
So
to
there-
make up for.
There are differing views about it, and I think if you polled the people in this room, that you could find literature all over the place on it, which is why it's not
Yeah.
completely clear what the answer
But
is.
with respect to Part D, though, there have been a number of studies done, many of which we cite in the paper, which do show some impacts on overall spending and keeping it down for some of the same reasons we've been talking about earlier. If it does reduce, especially some of the short-term health risks, that can have some offsetting spending effects. It's not nearly, it doesn't fully offset the cost of the drugs, and in the CBO models today, a small part of the cost of, say, a drug benefit expansion is generally counted as savings on the rest of the acute healthcare side. But it is an important effect. I think this goes to, this whole discussion goes to why it's so important to have better measures of what really is accounting for the growth in healthcare costs. And we've done it historically based on things like, well, how much is inpatient, how much is outpatient, how much is drugs. A lot of this discussion highlights how important it is to understand what's going on at the level of patients, individuals with different kinds of health problems. How are their health risks changing, their risks of complications changing, which can lead to savings? How is their cost of being treated in a given health state changing? And that's the kind of modeling that we tried to start in this paper. David's been doing a lot of work on this. BEA has, Charlie has as well. And I think there's a lot of potential for gaining better insights about just how much structural change is really happening in healthcare based on that kind of work.
I think we have time for, maybe 2 more questions. Any more questions? Go ahead right there.
For David, you said in your presentation, I'm sorry, Joe Minerick, Committee for Economic Development. You said in your presentation that the problem at the healthcare provider institution level is not the incentives, it is the quality of management. I think maybe I'm following up on Alice's question to you. Where is the incentive to get better management? And it seems like you're trying to say that there's something very different today than there was 5 years ago, 10 years ago. I guess I just don't see it. Could you explain that a little more?
I think it's increasingly the case that the incentives are in the direction of saving money is a way to make money. And that was sort of the spirit of, the half of the ACA that wasn't about covering people. And that's the spirit behind the 600 plus ACOs in the world that Levitt Associates documents. And if you look at any survey of hospital executives and you ask them, what do you expect? Do you expect you'll have bundled payment or capitated payment contracts within the next 2 years? 3/4 of them say yes, even though at the moment they don't have them. So that's what's pushing them in that direction. What they're then saying is, okay, now how do I go about saving money? And if you look, if you compile a list of the things that you could do, there are about 20 of them. So if you sort of go through the IOM reports and all of that, there's sort of a range of things. Where these organizations are starting off is sort of a little bit like whatever they have a little bit of experience with, they're pushing. So a number of them have had experience managing high-cost patients, so they're moving into that domain. They're saying, gee, let's expand that program. Quite a number of them have experience, at least they've been pushed on their readmission rates for quite a while and their infection rates for quite a while. Those have been poster children of bad care. So readmission rates are plummeting and infection rates are plummeting. Those are all the easy things, but they're then sort of thinking about how do I really change the operation of this institution in a more fundamental way. And that's, I think, where they're running across this problem, which is that they don't know how to do it because they don't really have a lot of management training and they don't really have much expertise in changing the institution or working with the skilled providers who work at those organizations, even though now many of them are actually salaried by those organizations. And so that's the problem that they're running into. And that's where you see it, is these folks sort of crying out for help along those lines because they think the world is changing and they want to get ahead of it, but they're not totally sure how to do it.
One more question? Right here.
Thank you. John Graham from the...
So, you'll just have to speak up. Go ahead.
John Graham from the National Center for Policy Analysis. I want to ask about Professor Rivlin's issue about the political challenge of affecting these changes, but I think perhaps the whole panel could pitch in. Out there, voters and citizens don't know anything about ACOs or bundled payments. but now they all know the names of the ophthalmologists in Miami who billed $6 million to Medicare. So the democratization and crowdsourcing of this challenge is surely going to have an impact on the ability of the political system to respond. And I just wonder if the panel can comment.
I thought you were going to go the other way. I thought now that I know him, I should use him.
Yeah, well, maybe that would be the effect. I mean, I don't know.
He's good at getting a lot of services. Alan.
Yes, I think that's that's right. I mean, that it's got to be usable information. The name of the ophthalmologist in Miami may be interesting, but it doesn't really tell you much about what you ought to do in your town. I think the problem that ACOs face is not to go the way of HMOs. If they move, if they get too many people angry too quickly by not giving them the treatment that it may be less effective, but they think they want it, then they're in deep trouble, and you get a backlash. So it's a narrow window of opportunity there.
Anybody else, Joe or Mark or David?
The moral equivalent of the CMS data dump is Castlight, which is the private sector leader in this. And it's amazing how many people want that because they're in these plans with very high cost sharing, so they want to know how much they'll pay. In Massachusetts, we put into the law from a couple of years ago a provision that insurance companies have to be able to tell you in real time what your cost sharing would be for any service anywhere. And I would be very surprised if that kind of thing doesn't spread. Because when consumers think about healthcare, of course, what they're thinking about, as Charlie said, is their out-of-pocket payments. And to have a very high cost-sharing plan and not be able to know how much it's going to cost just drives people batty. And so I would be stunned if we don't see more action at the state level or at the federal level to address that.
So I have to object a little bit to Alice's representation of HMOs being the devil. They weren't, there were things that were called HMOs in the 90s. They were not.
I'm only talking about the politics. There was a backlash.
No, there was a backlash, and it was a legitimate backlash. What I'm talking about is how do health plans operate, and Kaiser Permanente existed then too. The fact is that there was a big push to create something called HMOs, but they didn't have any of the tools. I think the insurance industry has learned from that experience. There are some more tools, but also I think there's more pressure from employers. I think employers explain an awful lot about what's been going on in the early part of the 2000s about health spending. Employers are the ones that are pushing because they're the only ones who have an effective voice in the system that we have now. And they're not pushing for that kind of a system. They're pushing for something where, interestingly, it does matter what people think. And I think the critical question is, how do we get people to be more realistic about what their expectations are? Consumers and, for that matter, practitioners.
I just would add and kind of keep with the ACO idea is different in two ways from HMOs. One is that it's not all the way to capitation. It's this sort of second track and gradual. And the other is it's much more active engagement of those clinicians that David was talking about earlier. They're the people who know the most about delivering care, and maybe they're not that experienced with management yet, but they have a lot of opportunity to improve care. But I would like it to get back to the original question on the release of information and consumer engagement, and this is another opportunity for me to say both and. If you look at what happened with Medicare Part D, as we talked about in the paper, there was a huge shift in how drugs were prescribed from brands to generics. It went from like 50 to over 80% among the non-low-income seniors in a matter of a few years. And you think about, well, could we have gotten there with something like an ACO approach where providers had a bit of a payment incentive around using more generics? People have tried that before, didn't see that kind of response. So the consumer engagement and consumers really believing that brands and generics were the same and then having an opportunity to save money, having the transparency, meaningful transparency, and the cost savings opportunity really shifted, and I think that's had an impact on subsequent prescription drug innovation, and a reason why companies didn't meet their subsequent targets, and a reason why they are really shifting towards no more Me Too's. We're not there yet for physician services, and while I think the release of the Medicare claims at the physician level has led to a lot of headlines and will lead to some additional attention, what I think people would really like to know is not which ophthalmologist billed the most to Medicare, but which ophthalmologist is going to give me the best results for my cataract or other eye condition at the lowest cost. And this information is not that. It's also, if you look at some of the highest cost billing in Medicare, a lot of it's fueled by a payment system that's still very much fee-for-service. Those Part B drugs are, I think, sort of the poster child for fee-for-service reimbursement, where it's just passed through for the doctor, essentially, and not much consumer engagement, not anything like Part D on the consumer side. So we still got, we've still got a ways to go to get to David's garden party, but hopefully we're moving in the right direction.
All right, with that, let me just thank the panelists for the great discussion. And Alice, I'm going to turn it over to you to just get everyone to do.
Oh, careful. You're connected.
Connected, sorry.
It's okay.
Connection is good, usually. Yes, I just want to thank everybody for coming. It's been a stimulating day. We hope you'll stay interested in all of this and watch for future publications out of Brookings and the Engelberg Center and other places. Thank you very much.